thank you very much for the introduction. It's a great honour and privilege to be here to present PathLAKE, Pathology Image Data Lakes for Analytics, Knowledge and Education, which is our consortium that is funded by the Innovate UK Challenge in the same way as David and Darren's is. The consortium is based here in Coventry. This is actually, this building up here is the Clinical Sciences Laboratory wing at the University Hospital Coventry in Warwickshire, just a few miles away across the other side of town. This is where my new office is placed in this building. It's even smaller than the last office I had, but it does have a window. Still no parking slot yet. Helpfully, this building is as far away as you can get from the pathology lab, which is at the far end of the hospital. So it's a long walk to the lab, but at least I get less disruptions during the day. So Nasir and I are based here in Coventry in Warwickshire. Manuel Saltateles and Jackie James are Queen's University Belfast, our collaborators in Belfast. Emma Draka and Ian Ellis are based in Nottingham, and we're collaborating with them on breast cancer. Claire Verrill and Jens Richter are at Oxford University and Oxford University Hospital Trust, and are collaborating with us as well. And our commercial partner is Philips, with Peter Hamilton here as leading that group. So that's the consortium that forms PathLAKE, and we all know this. This audience is well informed as to the current capacity problems that are facing cellular pathology. We, as pathologists, are only too aware of how important cellular pathology in particular plays in the lifetime of our patients. Often it's the most important part of the diagnostic pathway patients go through. These results are relied upon for years to come. And the crisis that we're facing is built on a number of issues. There's problems with recruitment, but there's also advances in care, a drive to earlier diagnosis, all of this leading to increasing complexity of the samples that we're dealing with. And we have an aging population itself, a product of the success that is the National Health Service. So all of these problems are increasing in number. And we're still using, for the large part, light microscopes, although in Coventry we've been at the vanguard, really, of transitioning through to digital workstations for our diagnostic work. And it is certainly true, as Darren has said, and there's been several other presentations, Juan's presentation yesterday, showing that just digitizing work, working digitally as a cellular pathologist, does give you some inherent gains of productivity and efficiency. But we're still a long way off having computer-assisted diagnostic tools to help us in the jobs that we do day in, day out as diagnostic pathologists. This is all still very much research grade, and the mission of PathLAKE is to change that. And now I've been clinical lead. I've given up now, thankfully, but I've been clinical lead in UHW for 10 years. And over that time, I've had a varying relationship with the finance department, best usually described as strained. And without doubt, this is the most useful piece of information they've ever given me. This is late on in our journey as clinical lead, when we finally realized that the way to get the impact of increasing workload through to the finance department was to count the number of slides that we're doing. So this is the monthly request rates we've had in UHCW over the last 10 years. This is numbers of requests coming into the lab, a modest increase over 10 years, 2 to 3% a year, something like that. Nothing too startling, certainly nothing to excite the finance department about difficulty with workflow, increasing demands. We need more posts, we need more staff. They're not going to be shaken by that. But if you convert it to number of slides, it's twice the number of slides that we've generated in that time. Just as a measure of the increasing complexity of the work that we're dealing with. And all these slides need to be produced, of course, stained and looked at, and that's the work, of course, that we do. So, PathLAKE's goals and objectives is to digitized diagnostic pathology in these centers, to build a data lake of real-world NHS data, real patient data that we can use for research to drive the development of artificial intelligence in digital pathology. Importantly, as David was mentioning, really to establish an ethical framework that's based around involving patients and public partners in the ethical framework of how this data is used, what access is granted to it, and what we get in return for giving access to it. We want to develop a world-class centre for artificial intelligence in digital pathology and work with industry to make these things happen, to work with regulators and academic partners to develop algorithms that will go through regulation and into practice and be sustainable. And obviously, we want to share this benefits with the world and, above all, deliver a sustainable model for PathLAKE into the future. So I'm going to hand over now to Nasir, who's going to take you through how we're going to do this in more detail.
Okay. Thanks very much, David. As a computer scientist who have been working in this area for about 15 years, I'm very much interested in taking some of the algorithms that we have been developing and groups like ours have been developing all the way to clinical adoption. And we've seen and heard about filters of reality yesterday about biomarkers and barriers to entry this morning by David Harrison. Quite a lot of that, in essence, applies to the algorithms that groups like ours and other AI innovators have been developing all the way to clinical adoption, how to deploy those methods. So I'm going to talk a little bit about what our vision is to achieve that goal of the clinical adoption for some of the innovative algorithms that we have been developing and the exciting work that has been taking place pretty much all over the place recently. So first up, obviously, we need to make sure that labs are digitized and data is generated from slides. And then we all know and we've heard about repositories of well-curated data with properly annotated labels. And I think that's quite important to make sure that we have got that high-quality data set for AI innovators available so that we can train our algorithms on good quality data sets that is passing the test of multicentric and all other issues related to that were mentioned during the course of this conference so far. And once we have that high quality data repository, innovation can then be accelerated and hopefully new players can be brought into the whole landscape as well. And with that innovation, we have another major barrier to entry, which is validation of that innovation and making sure that the regulatory approvals, they are taken care of. And all of that is only possible if we have good quality data sets and AI built on those data sets that passes those tests right from the beginning. And it's only then that you can take your algorithms to commercialize with the help of commercial partners who have route to market. Once the algorithms are commercialized, you can then adopt them clinically. So that's really the route to clinical adoption in our view. All this AI innovation that we're going to be developing and working together with our industrial partners to develop is really based around three major pillars to start with. So these three pillars are on exemplar projects concerned with diagnostic efficiency in colon and prostate cancer with the aim of saving the pathologist time, reducing the diagnostic errors, and reducing the turnaround time as well. We then move on to prognostic AI, which is two particular projects. We have some of the world's most precious cohorts from Nottingham on breast cancer and also very precious cohorts on prostate cancer. And the aim there is to develop AI and validate AI for computer-assisted prognostic indexing and grading for those two types of cancers. And obviously hoping that that would then result in better, improved patient outcomes and better use of treatment costs. The third major pillar that we have is on selection of patients for targeted therapies such as immunotherapy in two particular cancers, in lung and colon cancer. This is again based around the idea that some of these therapies are extremely expensive, cost the NHS in this country quite a lot of money, and we want to make sure that we achieve selection of patients, the optimal selection of patients to result in cost savings for the NHS and better outcome for patients. So our major objective is to deliver a data lake that consists of retrospective cohorts, the kinds that I mentioned, but also prospectively collected data with linked clinical metadata that comes from the real world, from the NHS. And NHS has its own, for all its ills, it has a major advantage that it consists of data for almost everyone living in the UK, right from birth all the way to death. So we aim to collect these data sets for research and development of AI in pathology. Along the way, it is our objective to develop proof of concept products for these exemplar projects that pass the test of regulatory approvals and conduct health economic studies to demonstrate NHS savings and patient benefits as well. And on the data side, our goals are that we want to put together these unique, high-quality, multi-centric data sets with automated management as much as possible. And we really believe that one of the unique features of our data lake is that we're introducing these longitudinal updates at regular intervals so that data is not static. If there is any change in patient history in the clinical follow-up, that the data is updated with that extra bit of information. To put together this kind of data lake, we need to ensure that there are some important issues like the security, privacy, and ethics that are taken care of and handled with extreme care. The repository that we're going to be putting together will have a web-based interface for efficient search and querying of the repository, and annotations that can be ported and can be downloaded for AI development. Interoperability has been talked about and is really a major founding principle of all these centers, and we're committed to the use of open standards and APIs as much as possible to ensure interoperability. And obviously, we want to ensure that there is sustainability, and these data lakes that we are going to be putting together are not stagnant, and they don't just disappear after 3 years. So there is a plan for extensibility and integration into the national data sets in future as well. The paradigm of design that we have put together, this very high level, is that we're going to be ingesting data from LIMS and scanners into local data ponds and then making their way into the consortium data lake that is then linked to the analytics engine that is going to be based here. And the idea there is, again, to ensure that we operate on open principles as much as possible. So we're working together with Glencoe, and we'll be looking at validated annotation tools so that this data is high quality in terms of annotations as well. And we have NVIDIA as an official partner for the analytics engine. The major use cases, some of them I'll quickly mention here. The idea is that the SMEs, researchers, new kids, somebody mentioned a script kid, somebody comes along with new algorithms, but really smart ways of doing things, solving problems. They would be able to apply for access to the data, and if they have a good case, they will be able to download the data and conduct their own experiments and come up with new discoveries and new biomarkers. Eventually, we want data from the lake to move into a national data repository, so we're looking to link up with Health Data Research UK, Genomics England, and other centers so that we can have an even bigger resource for research and development. Use of patient data, even if it's anonymized, poses very interesting kind of ethical challenges. So we're looking to develop a robust ethical framework together with our expert on ethics in AI from here, Professor Tom Sorrell. And we'll be looking at some of the major concerns that have been raised by patients and publics in terms of control, confidentiality, transparency of the data and access to data, and making sure that the intent and purpose here is eventually to improve patient care. I think it's at the end of the day just a trade-off between risk and benefit, and we'll be working together with patient-public representatives. They are on our ethics committee, on our data lake management committee, to make sure that some of those concerns are addressed in the best way possible. And as I mentioned before, we have a responsive system here so that we can redact data for patients who opt out from the data lake. Just to give you an idea of some ballpark figures here of the numbers of cases that we are thinking about putting into the data lakes. Coventry is going to be putting in probably the largest contribution into the data lake, mostly prospective data, but also some retrospective data. Belfast contributing mainly on colon and lung, Oxford on prostate, and Nottingham on breast, and we have a new partner from Surrey who will be contributing some data for various tissue types. Altogether, we have an estimate of around 60 to 70,000 cases for 10 different tissue types, multicentric data. We've also been approached by several large trialists who would like to put their data into the data lake. And I think that's going to add quite a lot of value to the data lake as well. This data is going to be not just the whole slide images, but also linked clinical data and pathology reports, as well as clinical follow-up data. And another very important component of the data lake is going to be the quality of the annotations that we are going to ensure is up to standard. And we aim to have about 50% of the data annotated in the lake. And we hope that this would then produce the world's largest repository of annotated, well-curated pathology imaging data sets. And as I mentioned, there are various use cases for all kinds of interested parties who may be interested in getting hold of this data. On the annotation front, we'll be developing a front end for annotating these images in the data lake using validated but preferably open annotation tools with emphasis on the quality of who would like to put their data into the data lake. And I think that's going to add a lot of value to the data lake as well. This is going to be not an example of what looks like an example of annotation, but actually it is an example from Simon Graham's work, one of the PhD students in my lab, on segmentation of glandular structures in colorectal whole slide images. This was a paper that was just accepted in Medical Image Analysis a couple of months ago. In our group, we have been working on developing image analysis and AI-based algorithms for computational pathology for almost 15 years. And while we appreciate the advances that have been made in AI and deep learning in recent years, we also understand that there are some limitations, and we value very much the classical kind of image analysis algorithms that we've learned the hard way for several years that could be put together with the AI-based algorithms. And our approach here is that we use AI really as a building block and usually at the bottom level to detect basic kind of primitives, classify them, segment them, and build on top of that with statistics and other computational models that could be then leveraged to extract value from this data. One of the major pillars, the E in the PathLAKE, is education and training. And here we have two major components, one on training of pathologists, now we have more and more pathologists interested in digital pathology and practicing digital pathology. We need to make sure that they are well trained on how to report on digital pathology. We also believe that there is room for improvement in the guidelines for reporting using digital pathology and EQA. And I also believe that the consortium, we have a consensus that the pathologists also need to be trained on how to read the outputs of AI algorithms and report using those readouts of AI algorithms, as well as looking out for caveats that could be there in the outputs of AI algorithms. We aim to also hold annual workshops for training of pathologists, but also very importantly, I think we have a very nice education program for data scientists who are interested in computational pathology, not just data scientists who are going to be part of our consortium, but also data scientists who are going to be involved, are involved already in computational pathology. And one of the major ways of attracting data scientists to computational pathology we've seen with the success of Chameleon and other similar contests is to hold challenge contests, to put data out there, nicely annotated data for well-defined problems that are of clinical relevance, to make sure that people are coming up with cutting-edge algorithms to then drive innovation forward. So we're going to be holding master classes. We have some of the distinguished faculty in Anant Madhabushi, Joel Saltz, and Jeroen Wenderlock, who are going to be on our distinguished faculty delivering master classes to this network of data scientists on a regular basis. And we are in the process of engaging some of the other machine learning scientists to come on board as distinguished faculty so that they can also educate and train the next generation of data scientists in computational pathology. I think that's me. I'm going to hand over to David again, who's going to tell us about how these algorithms are going to go to clinical deployment.
Yeah, I think we're probably nearly out of time, but you may recognize this slide. It's one of Peter's. He showed it yesterday. And just to emphasize, this is a team effort, really. You've got a big team of academic and NHS institutions contributing to this, but also it's important to build on the existing expertise in the commercial sector to ensure that these products, as they go through their entire pathway from conception to delivery, match up to standards that'll be needed for regulation and regulatory approval. So that's carefully designed into the way work streams have been thought through. And also, as Nasir was saying, really, the whole idea of this project really is to provide a resource that's open for business, particularly small and medium-sized economic institutions in the UK, to build the economy in this sector. So not just access to the data, but access to the pathologist expertise that's needed to provide the ground truth data, the information of the clinical roles, and so on, access to the data scientists to help deliver the research which is needed, as well as access to health economics and modeling and how these projects can be put to work for the economy and for the country. And that's really, in essence, one of the key objectives behind the whole industrial strategy fund is to grow the UK economy in this sector. So all of this is a key part of our program of work. So I'm going to leave this slide as my final slide. So we have declared that we are built to last. We've got 3 years of funding, so we'll see how we get on. But these are our future plans for revenue streams going on beyond that when that funding runs out, to provide services to companies with annotations and slide scanning, access to data, co-developing, we hope, successful algorithms which will produce revenue streams, and in providing data lake access to key partners. In this stage, as we all know, data is king and an extremely valuable commodity. So thank you very much.